Hello, I'm Laurie Sehn from BC Cancer in Vancouver, Canada, and today I'll be presenting data which is summarizing a recent paper looking at the use of BTK inhibitors for the frontline treatment of CLL. These are my disclosures. And this information has just been recently published in a manuscript with my co-authors, including Dr. Banerjee, Dr. Ah, and Dr. Robinson, and it's currently in press in Current Oncology and slated to be released in December 2020 issue. By way of background, we know that there are numerous novel agents that have been recently approved for the treatment of CLL. So we have BTK inhibitors, including ibrutinib and acalabrutinib. There's the BCL2 inhibitor, venetoclax. And of course, we have PI3 kinase inhibitors, including idelalisib, which have been primarily indicated for relapsed refractory disease. So BTK is a TEC family protein kinase, which functions downstream of the B cell receptor to regulate B cell proliferation, maturation, differentiation, migration, and apoptosis. So BTK is clearly an instrumental kinase. It's also expressed in other hematopoietic cells across all lineages, with the exception of T lymphocytes and plasma cells. And importantly, it's overexpressed and activated in CLL cells, which really explains why BTK inhibitors have been so profoundly beneficial in CLL. So ibrutinib was first approved in July of 2016 as monotherapy for untreated CLL based on a demonstration of improved progression-free and overall survival versus chlorambucil in the RESONATE-2 trial. Subsequently, in November of 2019, it was approved for untreated CLL with obinutuzumab based on ILLUMINATE study showing an improvement in progression-free survival compared with obinutuzumab and chlorambucil. We also saw acalabrutinib approved for untreated CLL in November of 2019, both as monotherapy and in combination with obinutuzumab based on the ELEVATE treatment-naive trial, which demonstrated an improved progression-free survival compared with obinutuzumab and chlorambucil. So far, we have a lack of results looking at head-to-head trials of different BTK inhibitors in CLL. So choosing the optimal BTK inhibitor for an individual patient really will rely on reviewing the efficacy and safety data that's published in the literature, as well as practical factors, of course, such as access. So the paper aimed to review the pharmacologic features, efficacy, and safety of BTK inhibitors currently approved in Canada. Also to discuss additional BTK inhibitors in clinical development, and to discuss some practical considerations to consider when selecting a BTK inhibitor in the Canadian treatment landscape. So first, let's think about BTK inhibitors selectivity and pharmacodynamics. So the BTK inhibitors that are currently approved are considered irreversible BTK inhibitors. And looking at ibrutinib, in vitro studies have demonstrated that ibrutinib actually has relatively low selectivity for BTK and has numerous off-target inhibition effects, including other kinases such as TEC and EGFR family kinases. This may explain its safety profile, where we know that safety issues include the development of rash, diarrhea, arthralgias, atrial fibrillation, and bleeding risk, some of which are likely directly attributable to these off-target effects. When we look at some of the second generation irreversible BTK inhibitors, it's noteworthy that they are more selective for BTK by and large, and there seem to be fewer off-target effects, which may relate to fewer adverse events. So this table summarizes the irreversible BTK inhibitors that have been in development and largely approved. And you can see that there's a range in BTK selectivity and also a range in the major off-target effects between different agents. Ibrutinib, of course, has quite a few suspected off-target effects, some of which have been directly correlated with the side effects that have been noted with ibrutinib. Currently in development, there are also reversible non-covalent BTK inhibitors being developed. So we know that resistance to the irreversible BTK inhibitors such as ibrutinib can develop through mutations of C481S or downstream PLC gamma 2. There are now a class of reversible BTK inhibitors in development that interact non-covalently with the ATP binding site of BTK. Agents under development include vecabrutinib, LOXO 305, and ARC 531. And these are currently all undergoing evaluation, and they've been demonstrated, at least in vitro, to be able to inhibit BTK even in the presence of the C481S mutation. So what do we know about efficacy of BTK inhibitors in the frontline treatment of CLL? Well, we've now had numerous upfront clinical trials performed. This table summarizes the data that we know relating to ibrutinib, where we have 4 large trials done in the upfront setting. These trials have included both elderly patients as well as younger patients. For the RESONATE-2 trial, which compared ibrutinib versus chlorambucil alone in a more elderly comorbid patient population with CLL, we saw a profound improvement in not only progression-free survival, but also overall survival. We've also seen a comparison of ibrutinib against, or ibrutinib and rituximab against bendamustine and rituximab, which again has shown a profound improvement in progression-free survival. We also have a comparison of ibrutinib and obinutuzumab versus chlorambucil and obinutuzumab, which showed an improvement in progression-free survival. And then finally, we have a direct comparison of ibrutinib and rituximab versus the very intensive chemotherapy package FCR. And it's quite noteworthy that we saw not only an improvement in progression-free survival with ibrutinib and rituximab, but also an improvement in overall survival. For acalabrutinib, we now have 1 trial performed in the upfront setting. This compared acalabrutinib, or the combination of acalabrutinib and obinutuzumab, with chlorambucil and obinutuzumab, and we saw a marked improvement in progression-free survival. There's also an ongoing trial looking at zanubrutinib in the upfront setting, but of course this is still ongoing and we don't yet have any data. So what about the safety of BTK inhibitors? This table summarizes some of the main safety factors that have emerged from the clinical trials in the upfront setting. Of course, on this list are some of the adverse events that we're quite familiar with as we manage them in our own clinic, including diarrhea, arthralgia, headache, atrial fibrillation, hypertension, major bleeding, and infection. While some of these are quite common in terms of, we see them quite frequently occurring at low-grade levels, fortunately, most of these adverse events are relatively infrequent in terms of grade 3 or higher adverse events. We're going to discuss some of these adverse events in detail, looking at how frequent they occur and as well what some of the typical management strategies might be. So starting with diarrhea, This is a relatively common side effect and is thought likely to be due to the off-target effects on EGFR. In terms of all-grade diarrhea, this can occur in up to 40% of patients receiving ibrutinib, but most of these patients have low-grade diarrhea, with less than 5% of patients experiencing grade 3 or higher diarrhea. Mostly this is an early event. It often occurs within the first 6 months, and the median duration is usually 6 to 20 days. It typically resolves quickly and often without the need for treatment modification of the BTK inhibitor. Antidiarrheals such as loperamide can be used if necessary. In patients who develop more extreme symptoms, including fever and abdominal discomfort, certainly patients should undergo an evaluation for the possibility of infection. For the rarer patients who experience grade 3 or 4 diarrhea, treatment can be held temporarily until the diarrhea improves to at least grade 2 or lower, and then treatment can be reinitiated, sometimes opting for a lower dose, particularly if the diarrhea recurs. Rash is also a fairly common side effect that we can see, occurring in up to 27% of patients receiving ibrutinib within the clinical trials. It often also occurs early and incidence can decrease over time. It can present as a mild, non-pruritic petechial type rash, which sometimes has a later onset, or as a more early onset palpable pruritic rash that can be variable in its severity. And the rash is thought to possibly be related to off-target effects on EGFR. The rash can sometimes be associated with peripheral edema, which can be a little bit more difficult to manage. But in general, rash is self-limited, usually with a median duration of 31 days. Often there are no dose modifications required of the BTK inhibitor, as patients can recover from the rash quite spontaneously. For those patients who have the palpable pruritic symptomatic rash, they can be treated with a course of topical steroids and even oral antihistamines. Arthralgias are also a common side effect that we see in clinical practice. It's been reported in about 20 to 22% of patients receiving ibrutinib on clinical trials, and frequently it's generally low grade. It often occurs early and can resolve spontaneously without need for treatment modification. The rates for acalabrutinib and zanubrutinib, the next generation BTK inhibitors, appears to be marginally lower, but again, we don't have any head-to-head comparisons. Generally, there are no dose modifications that are needed, and patients can often be managed with supportive medications to include primarily acetaminophen. Rarely, patients can be considered for a short pulse treatment of prednisone, although I must say I almost never do that in my own clinic. Anti-inflammatories can also be used, but keep in mind that these patients do have a higher bleeding risk, so anti-inflammatory agents should probably be limited if at all possible. In patients where the arthralgias are persistent and very significant and sometimes can impact the quality of life, well, it may be necessary to dose reduce and continue with either a lower dose or reinitiate after a brief break. Headache is an interesting side effect that somewhat uniquely has been seen on acalabrutinib, where it can occur in about 40% of patients. When it occurs, it's generally low grade, often self-limited, and also quite easily managed. Management typically involves using acetaminophen or caffeine, and generally patients can be managed without the need for dose alteration of their BTK inhibitor. Atrial fibrillation is one of those side effects that we certainly need to be aware of, and particularly concerns many of us the most. So it has been reported in approximately 10 to 12% of patients receiving ibrutinib on clinical trials. The grade 3 or higher incidence, however, is lower at about 4 to 5%, although some higher rates have been reported in real-world studies. Typically, this is an event that can occur early, with the incidence then remaining either constant or even declining over time. For the next generation BTK inhibitors of acalabrutinib and zanubrutinib, the overall rates appear slightly lower at 4% and 2%, with minimal grade 3 or higher events being reported. But again, we should understand that head-to-head comparisons are not yet available. Management of atrial fibrillation often includes starting an anticoagulant, so important to know that this has to be done with care, particularly since these patients have a higher bleeding risk. In terms of ventricular arrhythmias and sudden deaths have been rarely reported, particularly so far only with the use of ibrutinib. So it's really important to be aware of the risk of atrial fibrillation and to monitor for symptoms suggesting the development of atrial fibrillation, and to have a low threshold for starting a cardiac workup. If it occurs, generally delaying or stopping the BTK inhibitor is not recommended. So most of these patients can undergo evaluation and be managed for their atrial fibrillation without need to stop the BTK inhibitors. In my own clinic and in general, it's recommended that atrial fibrillation should be managed in consultation with a cardiologist or a cardiac oncologist, and patients should undergo a careful assessment for their stroke risk as well as their bleeding risk to consider management strategies. Rate control is often required with the use of beta blockers typically used. In general, as I said, BTK inhibitors are not necessarily discontinued, but in a select group of patients, this may be required, particularly if rate control is difficult or if the atrial fibrillation presents recurring problems. Hypertension is also a frequently encountered adverse event and has been observed in about 20% of patients receiving ibrutinib on clinical trials, and even at a higher rate in real-world studies. It can increase over the course of treatment with ibrutinib, so it really highlights the importance of monitoring these patients long-term. The mechanism of the hypertension is not entirely elucidated, but it may be due to either indirect downregulation of PI3 kinase or VEGF, or off-target effects. The rates of hypertension appear lower possibly for second-generation BTK inhibitors such as acalabrutinib and zanubrutinib at 5 and 10%. However, again, we don't have head-to-head comparisons. Importantly, patients should be monitored for blood pressure regularly, and when hypertension is recognized, patients should be managed appropriately, usually without modifying the BTK inhibitor dose and managing the hypertension. Bleeding events are also a risk with ibrutinib, typically presenting as minor bleeding or bruising, which can occur in up to 50% of patients, with major events fortunately being much lower, but even up to 11% on clinical trials with longer follow-up. And in fact, real-world studies have actually suggested a higher rate of major bleeding events. Bleeding events can often occur early and within 1 year, but essentially can occur throughout the time that patients are on BTK inhibitors. Of course, we don't have head-to-head trials of BTK inhibitors to compare their risk of bleeding events, but it's important that we eventually have that information, and the information should certainly control for anticoagulant use and antiplatelet therapy use so that we can understand the differences in the risks between the different BTK inhibitors. For major bleeding, of course, probably the best course is really to focus on prevention. So the use of concurrent anticoagulation needs to be done with care and generally should be avoided in these patients. If it is required, however, Certainly alternate CLL therapy can be considered, or otherwise using perhaps the novel anticoagulants such as apixaban or enoxaparin. Also important to remember that if patients require surgical procedures, that it's recommended that the BTK inhibitor be held both before and after the surgical procedure, and that would be 3 to 4 days before and after for minor surgical procedures and 7 days before and after a major surgery. For patients that experience major bleeding events, of course, these need to be managed acutely and appropriately based on the nature of the bleeding event, but typically we would discontinue the use of the BTK inhibitor either temporarily or even permanently if the risk of recurrence is high, and to consider transfusion as necessary. Infection is also a very important risk that needs to be on the minds of clinicians, in that there has been an increased infection rate demonstrated with ibrutinib in clinical trials, particularly pneumonias and opportunistic infections. This may be in part due to the ibrutinib-mediated inhibition of both BTK and ITK, which is expressed on T cells, leading to altered innate and adaptive immune function. However, we know that infections can also occur with the next generation of BTK inhibitors, although it's possible that it may occur to a lesser extent, but again, we don't have head-to-head trials. Fungal infections and atypical infections have been reported, particularly aspergillosis and PJP pneumonia have been reported with ibrutinib and should be considered in the right clinical scenario. And also we know that the risk of these events, including infections in general, is heightened with the concomitant use of steroids. So patients should be treated with steroids judiciously, and in general, steroids should probably be avoided if patients are on BTK inhibitors. In terms of management, of course, prevention, again, should strongly be considered. Patients can be considered for prophylactic acyclovir or valcyclovir due to the increased risk of varicella zoster. Patients can be considered for PJP prophylaxis, although I'd have to say that the evidence for this is weak, and I tend not to do this within my own clinics. And also important to remember that live attenuated virus vaccines should be avoided in patients who are immunosuppressed. When patients experience infections, for the majority of infections, which are grade 1 to 3, we don't need to stop the BTK inhibitors, and patients can be treated for their infections while their BTK inhibitor continues. However, for patients who experience significant grade 4 infections, generally we would recommend delaying the BTK inhibitor until the infection has resolved. Certainly, these patients need to be fully evaluated for the possibility of atypical infections, including fungal infections such as aspergillosis. When patients need treatment with anti-infective agents, we need to take care to be aware that there could be drug interactions between the BTK inhibitors and the anti-infective agents, and particularly if patients need to be treated with strong CYP3A4 inhibitors. In this case, the dose of the BTK inhibitor may need to be temporarily reduced and the patient monitored carefully for toxicities of the BTK inhibitor. So what about BTK inhibitor discontinuation? This table summarizes the discontinuation rates that have been reported in some of the recent clinical trials. You can see for ibrutinib, the discontinuation rates have ranged between 12 and 16%, and for acalabrutinib have ranged between 9 and 11%. The most common adverse events leading to ibrutinib discontinuation included infection, hemorrhage, atrial fibrillation, rash, and thrombocytopenia. In the ELEVATE treatment-naive trial, acalabrutinib was discontinued due to a variety of occurrences, including myocardial infarction, brain injury, and brain neoplasm, some of which, of course, were unlikely to be related to the treatment drug. We know that long-term tolerability and treatment with BTK inhibitors is important because the long-term steady use of BTK inhibitors is important to achieve optimal outcomes. Unfortunately, some patients do require dose reduction and interruption due to tolerability issues that can impact efficacy. Recently, we've seen data reported from the ECOG 1912 trial looking at patients who discontinued ibrutinib for reasons other than progression or death. And these patients had a median progression-free survival of just over 22 months post-discontinuation. So certainly some of these patients who discontinued BTK inhibitors don't need to go on to a next treatment immediately, and many of them can be monitored until clinical indication warrants a next line of therapy. Importantly, the rate of discontinuation in the real-world studies has actually been demonstrated to be higher than that reported in clinical trials. One of the primary factors for discontinuation for ibrutinib, for example, has been related to the incidence of atrial fibrillation. So to conclude, BTK inhibitors have certainly become a very important treatment for patients with CLL. Now we have several available to us in clinic, and we know that more are in development and likely to be coming. Head-to-head trials of BTK inhibitors in CLL patients are certainly lacking, but we look forward to more data emerging so that we can better judge their efficacy, but more importantly, their safety profiles. In the absence of this comparative data, it's important to understand the literature and to be aware of the side effects and adverse events that can occur. And certainly when deciding on a BTK inhibitor for individual patients, the side effect profile should be considered against the patient's known risk factors. For example, if patients are known to have cardiac morbidities such as low ejection fraction or premature ventricular contractions, it may be that acalabrutinib might be a preferred agent over ibrutinib due to the apparently lower cardiac toxicity associated with this drug. Similarly, for patients with propensity toward skin toxicities, acalabrutinib may be associated with a lower rate of skin events due to the reduced likelihood of EGFR-mediated toxicities. Zanubrutinib, of course, is still being studied and represents a novel alternative that may be shortly emerging as well. Importantly, as we do have novel BTKs emerge onto the market, choice of treatment should involve a discussion with patients and patient preferences, always balancing the risks and benefits in an individual patient. Similarly, when we think about starting patients on these long-term BTK inhibitors that require chronic treatment, the discussion between starting a patient on a BTK inhibitor versus a more time-limited intravenous therapy should be performed with patients as well. Thank you very much.